Okay, that's fine.
Good afternoon, everyone. Welcome to this month's BNTP. Today we have Dr. Patrick Chan presenting on the surgical management of traumatic brain injury. A reminder to all participants, please keep the cameras blocked and microphones muted. We will have time for questions at the end of the session. Anyone on the video conference can use the chat function to submit questions and I will announce them for you. I'll now hand it over to Dr. Patrick Chan.
Good afternoon, everyone. So I've been asked to talk about traumatic brain injury. So can everyone hear me?
Yes, I can hear you.
Okay, good. All right. Okay, now looking back at so traumatic brain injury, we all know about the case of Natasha Richardson in 2009 with a skiing accident, and basically she died from an extradural hemorrhage. Now, traumatic brain injury is the most significant cause of death from trauma, and it's one of the significant cause of profound long-term disability and carries a lot of long-term healthcare costs. The economic burden is significant, and it's estimated that in Australia the annual hospital cost is about $184 million in Australia per year. Now, what are the main causes of TBI? The main causes are major road accident, so motor vehicle accident are the main causes. This is closely followed by falls. But over the last decades, there has been a significant change in the demography with the less head injury related to the motor vehicle accident, even though it's still the #1 cause. But the overall incidence is getting less, from 5 per 100,000 to dropping to 3.2 cases per 100,000 per year. And there's significantly more patients that are having head injury from falls. Now, in terms of definition, this is a bit pedantic, but there's a difference when we talk about brain injuries or head injuries. So brain injuries is trauma to the brain, so within injuries within the intracranial content, while the head injury is more inclusive, that include all the extracranial head structures such as scalp laceration, skull fractures. Now there's a different way of classifying the head injury, and each classification gives us some information about the extent of pathology and the prognosis and treatment. So it can be classified according to the mechanism, whether it's a close or penetrating injury, whether it can be classified according to pathology, whether it's a diffuse type of injury or focal type of injury, and can be classified according to severity, whether it's mild injury, moderate, or severe. So just in a bit more details, so close head injuries is usually related to blunt force. It can be related to acceleration and deceleration, common in car accident when the car comes to a complete stop while the person's head continue to move forward in the same velocity. And once the head stop moving, the brain continue to move forward in the same velocity and contuses the front part of the brain, and then it decelerates backwards and contuses the back part of the brain. Or the close injury can also be a result of a direct blow to the head, such as a blunt object or heavy weight onto the head. A penetrating head injury that's related to a structure that pierces through, whether it's a bullet, knife, nail gun, scissors, toothbrush, anything. Now, pathology in terms of that can be sort of classified according to whether it's a diffuse mechanism. So for example, a diffuse axonal injury will involve the tearing and shearing of a diffuse area, a wide area over the whole brain. A focal pathology will be something that's more localized, such as a contusion, an extradural or subdural hematoma, tend to be more localized to a certain smaller specific part of the brain. It can be classified according to severity. So a mild head injury is someone who is GCS of 13 to 15, so that's Glasgow Coma Score. A moderate injury is 9 to 12, and severe is someone who is comatose, so someone who has a GCS less than 8. So Glasgow Coma Score is basically a scale to grade a person's level of consciousness, and it's on a scale from 3 to 15 based on the verbal, motor, and eye-opening reactions to stimuli. The simple way to look at it, so eye-opening has 4 points, verbal response has 5 points, motor response has 6 points, and if you have no response to any of those, so basically a patient who is dead will have 1 point for each, so that's 3 points for GCS. If someone who is awake, alert, oriented, moving about, they will have a GCS of 15, so 4 points for eye, 5 points for verbal response, and 6 points for obeying commands. And then the rest is sort of a scale between the two. Now, the head injury can also be classified according to the pathological types. So it can be extracranial, which will be something that's outside the skull. Intracranial, extraaxial, so will be outside the brain but inside the skull. Intracranial, intraaxial will be inside the brain. So examples, extracranial injury will be a scalp injury or skull fractures. Intracranial, extraaxial will be things like extradural hemorrhage, subdural hemorrhage, traumatic solenoid hemorrhage. Intracranial, intraaxial will be things like contusions or diffuse axonal injury. So looking at a normal CT brain, you should be able to see axial view, left side, right side, that's skull, that's brain, and ventricles. And everything should be mirror image one to the other side. Scalp lacerations or extracranial injury. Scalp laceration can be classified as simple injury or degloving injury. Simple would just be like a cut or laceration on the scalp. A degloving injury is something like this diagram that shows the scalp being almost peeled off from the scalp. And in kids, they can actually have significant blood loss due to their bigger head and smaller blood volume. That's an example of a CT scan of someone with subdural hematoma. So gadia is it's almost is the layer of the thick fibrous tissue under the subcutaneous tissue of the scalp. So subdural hematoma is a contusion or bruise under that layer. It has no significant sort of surgical consequence. Skull fractures. A simple skull fracture would be just like a linear fracture, a line across the on the X-ray or CT will appear as a simple fracture line. A depressed skull fracture, the one in the middle, it will show the skull flap and the fragment being depressed downwards. If it's more than 1 cortical thickness, means that if it's thicker, if the distance is further than the thickness of the skull, then that fragment needs to be elevated to reduce the injury to the underlying brain, to reduce the chance of post-traumatic epilepsy. and also to reduce the chance of having deformity. An open fracture or compound fracture is when there's a communication with the environment, so like a laceration over the scalp fracture. At base of scalp fracture, the concern about the base of scalp fracture is the neural structures. Sometimes it can injure the nerve, the cranial nerves, like that will potentially injure the optic nerve. Fracture through the temporal bone, you might concern about facial nerve injury. And another concern is CSF leak, so the leakage of the cerebral spinal fluid.
Okay, that's all right. Bye.
Okay, now this is a CT of someone with extradural hematoma. So extradural hematoma is when there's a bleed outside the layer of the dura. So brain has 3 layers of the membrane around it: the dura, the arachnoid, and the pia mater. So extradural is usually related to overlying fracture, and there's usually injury to a meningeal artery, and commonly middle meningeal artery. So it's usually high flow, high pressure bleeding, which means that it has high potential to expand, causing pressure to the brain and potentially life-threatening. It classically has that biconvex lens shape on the CT scan. Subdural hematoma, we divide them into acute subdural, subacute subdural, and chronic subdural hematoma based on the duration that the blood has been there and the consistency of the blood. So it's the bleeding under the lining of the dura, and therefore it has that crescent shape because it's a continuous space. It can actually flow from front all the way to the back, so it gives you that crescent shape appearance, which is different from the extradural. So in acute subdural, which is less than 3 days, it's solid clots, and therefore is hyperdense on the CT. When it's chronic, which is over 3 weeks old, it becomes watery, and therefore is hypodense on the CT. When it's between 3 days to 3 weeks, you get what we call subacute subdural hematoma. Is isodense to the brain because of intermediate consistency, and sometimes this can be missed on the CT scan. So one of the clues is the loss of the mirror image, the symmetry on both sides, and the bowing of the midline structure to the contralateral side. So in this case, this patient has subacute subdural hematoma right here, and you can see the surface of the brain is about here. Traumatic subarachnoid hemorrhage is the commonest cause of subarachnoid hemorrhage. It's related to trauma. It's injury to the arteries or veins along the subarachnoid space. Cerebral contusion is a more localized focal bruising within the parenchyma of the brain. So it actually appears almost like a hematoma type of appearance. We can classify them to cool or contra-cool. So a cool injury is when the contusion is right under the position of the force, while the contra-cool is the contralateral side from the rebound effect on the other side. Diffuse axonal injury, these are related to a more sort of a widespread force that involve the whole brain, involving a differential in the movement of the different structures in the brain because of their difference in density. So, for example, in a high-speed car accident with a rapid acceleration and deceleration, the gray matter will move in a different speed than the white matter So you get the shearing of the axons at the junction of gray matter to white matter. That's why you get sort of a widespread sort of changes throughout the whole brain. And also the left side of the brain relative to right side of the brain, it might be that with a bit of rotational force, one side of the brain will move forward while the other side of the brain will move backward, and you tear the central part of the structures, such as corpus splenium, corpus callosum, brainstem. Now, in terms of treatment, going back to the same case, in Natasha's case, one of the criticism was after her initial concussion, what they considered to be concussion, she actually was mainly just complaining of a bit of headache, but otherwise awake, alert. And it was a few hours later before she crashed and became unconscious. And so there was number one is failure to recognize that she had a head injury. The classical description of someone with extradural hematoma from a trauma is they have a brief loss of initial loss of consciousness, and then they wake up, and then they're fine, and then so we call the lucid period, and then afterwards you'll be followed by rapid deterioration again. So that's number one. Number two is there's a lot of fussing around and delay in transferring her to a center with definitive care. So she was actually transferred to a smaller hospital, waited for a few hours before being transferred to another hospital, before being transferred to another hospital in New York. So in terms of head injury, there's guidelines that we look at in terms of the optimum surgical treatment and the way of transferring and managing the patient. So one of the key reference that that's available for open access is the publication on guidelines for the surgical management of the traumatic brain injury by the Journal Neurosurgery, and is a guideline based on studies on over 700 journal articles with representatives from American College of Surgeons, the College of Neurosurgical Surgeons, the European Brain Injury Consortium, and the WFNS, and they are classified according to the level of evidence. Another good key reference to read is the one published by Neurosurgical Society of Australasia, and on the management of acute neurotrauma in rural and remote locations. Is a good read in terms of the early management of someone with head injury and the guidelines on the early management and transfer of the patient. So when we look at treatment of brain injury, the two key concepts, one of it is the concept of primary injuries versus secondary injuries. The primary injuries are related to the initial impact, the initial injury to the brain. And the secondary injuries happen later and is related to all the other additional insult to the brain, which is already vulnerable from the primary injury. So having hypoxia, hypotension, having ischemia, swelling of the brain, metabolic derangement, the free radical formation, having a hematoma that's expanding, having raised intracranial pressure that adds on to the secondary insults. Now, a large percentage of the people who are killed by brain trauma do not die right away from primary brain injury. Rather, a lot of them actually die days or weeks after the event. And this is usually related to the deterioration because of the secondary brain injuries. So there's not a lot that we can do for primary insult and primary injuries, apart from having a better road design, having better education to people in terms of prevention of falls and car accidents. There's more sort of research and studies and things that we can do for secondary brain injuries. So the whole thing is about preventing this secondary injury to the brain in terms of ischemia, the hypoxia, hypotension, the swelling, the hematoma expansion, and the raised intracranial pressure. Now, the factors that has been identified that adversely influence the outcome of a head injury, and I would like to draw attention to the final few points. Prolonged pre-hospital time, admission to an inappropriate hospital, delay or inappropriate inter-hospital transfer and retrieval, the relative inexperience of staff in rural and remote areas, the lack of medical facilities, the delay in definitive surgical treatment, that counts significantly to the factors that affect the outcome as well. So pre-hospital care or pre-definitive care, it's important, and so the recommendation is to follow the protocols from the EMST, the Early Management of Severe Trauma. So there's a course run by the College of Surgeons. It's based on basically the early hours of managing someone with severe trauma. And most of the surgeons, anesthetists, and rural doctors are required to attend to this course. So in terms of the primary survey, the early, if you're the first person at the scene or the first receiving hospital, the main thing is about keeping the patient alive, and that comes down to primary survey and resuscitation. So A plus, B plus, C plus, D, and E. So with A plus, so that's maintaining the airway, making sure the airway is patent, plus the cervical spine. So what it means is, while you maintain the airway patency, clearing the airway, you have to make sure you don't twist the patient's neck, keep the neck immobile. Beware of the cervical spine injury. B plus is breathing and ventilation, so it's not enough that the patient is breathing, but they have to be having ventilation. So things to watch out for is things like tension pneumothorax, which patient will be breathing but not ventilating. C plus is circulation plus hemorrhage control, so maintaining the blood pressure but control any hemorrhage. Disability, so assessing the patient's neurological status in terms of whether there's pupillary dilatation, patient's conscious state, and whether there's any lateralizing deficits, means weakness on one side of the body. Environment and exposure, so making sure a patient is not hypothermic. Exposure means that you examine area that you might miss, like renal angle, behind the back, under the armpit, in the perineal region. And this ABCD is not just keeping the patient alive, but also ensuring that you're reducing the secondary insults to the brain injury. Then the next thing is about transfer, and the recommendation is transfer to a trauma center with neurosurgical service. So in Victoria, we'll be looking at transferring to a level 1 trauma center that can deal with major trauma. So Alfred Hospital, Royal Melbourne Hospital will be the two key hospitals with level 1 trauma center. The next thing is also the timing and method of transfer. So timing, of course, is as soon as you can stabilize the patient. Method, whether it's by air, by road, whether it's by chopper or by fixed wing, that should be discussed with the receiving trauma center and will be guided by what type of injury the patient has and how stable the patient is. Things that you have to prepare for transfer, well, number one is make sure the patient is stable from after the primary resuscitation. And number two, does the patient need any additional support for the transfer, whether the patient needs to be intubated, For transfer, where the patient needs nasogastric tube to decompress the stomach content, indwelling catheter to reduce the bladder obstruction, spinal immobilization. Remember collar, the neck immobilization, the spinal board for back immobilization. Making sure that you have a good handover with the receiving unit. Consideration should be made about whether you need medical escort to go with a patient if they have severe injury or if they are deemed to be unstable. And if they are very unstable and you're from a far away hospital, then a consideration should be made whether surgery at the peripheral hospital will be appropriate. So sometimes, so in country hospital, patient with unstable and patient who are unstable who has a deteriorating head injury, and if they are in a location that's less than 2 hours, then after discussing with the receiving unit, it might be appropriate to just transfer them with mannitol, intubate the patient, hyperventilate the patient, and transfer as fast as possible to the neurosurgical unit. If it's more than 2 hours, especially in places like Northern Territory, some parts of Queensland and New South Wales, it may be that either the rural doctors or sometimes they'll fly the neurosurgical registrar up to the peripheral hospital and do the surgery there. So once the patients are received in the trauma center, so we go through the same thing again about the survey and resuscitation in terms of the A+, B+, C+, D, and E. And once the patient is deemed stable, then we organize for the appropriate investigation, including the CT brain. And in the CT brain, and the clinical pictures in the CT brain will help us to decide what sort of injury the patient have and what sort of treatment to follow from neurosurgical point of view. With a patient with a focal hemorrhage, like this patient with a subdural hematoma, some of them can be managed conservatively while others may need surgical treatment. And one of the things that we look at is the extent of mass effect on the brain. And one thing we look at is the extent of midline shift. So you probably hear sometimes we talk about how far, so basically it's just how far that midline has been pushed across from one side to another. And the other way to measure the extent of volume pressure effect is the volume. So we look at the length times the width times the height of the hematoma and divide it by 2. That gives us an estimated volume. Why is the mass effect bad for the brain? Well, Monroe-Kelly doctrine is basically, the doctrine says that the skull is like a fixed box, and inside a fixed box is your brain tissue, your blood, and cerebrospinal fluid. And when you have expansion of one component, or if you add any additional structure to that component, the overall volume stays the same. So some structures will start to compensate, and usually start with CSF and blood to accommodate for another volume. So initially, there'll be no raise in the pressure in terms of the volume to the pressure curve, as there's plasticity in the brain and the volume compensation from CSF and blood. But once it comes to a certain point, that compensation reached exhaustion, and that's the time when the intracranial pressure will start to rise exponentially. So intracranial pressure is the pressure within the skull at any one time. Normal range is about 7 to 15 in the supine adult. We consider someone having intracranial hypertension when their ICP is over, to be precise, with the latest number from Brain Trauma Foundation is 22 millimeter mercury. But somewhere between a number that's higher than 20 to 25 will be considered raised pressure, and treatment should be considered. What's the consequence of having a raised ICP? Well, how much your brain is getting the perfusion will depend on your mean arterial blood pressure minus your intracranial pressure. So the difference gives you the perfusion into the brain. If you have raised intracranial pressure and your MAP stay the same, you have global cerebral hypoperfusion. So sometimes you see that in ICU, we ask for the blood pressure to be bumped up because we want to increase the mean arterial blood pressure to increase the overall perfusion. The other consequence of having raised intracranial pressure, if it's focally on one side, if it's asymmetrical, it can cause herniation syndrome. So if the brain is pushed under the falx, so the falx cerebri is a thick fibrous tissue dividing the two parts of the cerebrum. So a subfalcine herniation is when the brain is pushed under the falx across to the other side. Ankle herniation is when the medial part of the temporal lobe is pushed across and under and over the tentorium. So that divides the supratentorium to the infratentorial component. So that with ankle herniation, it can compress on the midbrain. And it classically gives the patient the appearance of ipsilateral pupillary dilatation and contralateral motor weakness. A central herniation is when the brain, the whole structures of the brain push through the centrally through the tentorium. Extracranial herniation, if there's any defect in the skull or the skin, the brain can actually herniate through it. A tonsillar herniation is when the cerebellum and the brainstem herniate through the foramen magnum. And with that, that can cause medullary pressure and can cause instant death. So the early clinical features of someone with raised intracranial pressure will be a worsening or persistent headache. They can have repeated vomiting or nausea. In a later stage, they will start to get pupillary dilatation. They can become drowsy, comatose, and can be pre-terminal and die. So these are important features to recognize in someone with head injury, so that prompt treatment can be instituted. Now, methods of measuring the pressure ICP, well, one is clinical pictures. If someone is comatose, then we can actually put in the neurosurgical center, we can put in what we call an ICP monitor, intracranial pressure monitor. And there are various different types. There's the epidural transducer, where it just sits in the epidural space. The subdural, so we put it under the monitor under the subdural space. Or we can put intraparenchymal monitor. So these are ICP monitor with a measuring wire inside the brain. A ventriculostomy catheter is like a ventricular drain. So that is a catheter that goes into the ventricle, and that allows not just a measuring of the pressure, but also allows us to drain the CSF to reduce the ICP. Now, if there's a significant mass effect from a mass lesion, like extradural or subdural hematoma, the surgical treatment is to perform a surgery, such as a craniotomy, where we open up a window of the skull, and if it's subdural, we open the dura and drain the hematoma. So this is someone with an extradural hematoma and had a craniotomy. The blood was cleared from the extradural space, the arterial bleeding was stopped, and the bone flap was replaced. Someone with an acute subdural hematoma, so that's the hematoma compressing of the brain, and again, craniotomy, drainage of the subdural. Now with subdural hemorrhage, if the brain is sunken and there's enough room, then we'll put the scalp back in. Sometimes the brain is very swollen because of the underlying brain ischemia or injury. Then in that group, we'll leave the bone flap out. Now, so once a patient is in the ICU, if with severe head injury who are comatose, over the subsequent days in the acute setting will be management of raise the intracranial pressure. So a few things are recommended. One, keeping the patient's head up 30 degrees so that improve the venous drainage away from the brain and reduce the ICP. You keep the neck straight so that there's no venous occlusion. So make sure that the intubation tube is not having a tie that's too tight around the neck, making sure that the collar is not too tight. And then there's the whole thing is about treatment of hypotension. Make sure that the blood pressure is maintained. They're not hypoxic. They're not hypercapnic. We tend to keep the CO2 in the low normal, so somewhere between PaCO2 of 35 to 40 millimeter mercury. Make sure the patient is normal glycemic, and all the biochemical and metabolic markers are within the normal limit. Make sure they are not hyperthermic. Give them seizure prophylaxis to prevent seizure. Sometimes the patient will be kept sedated or paralyzed. That reduce the anxiety, reduce the agitation, reduce the cerebral metabolism to reduce the ICP. And nowadays we tend to use propofol because of it has a better metabolic suppressive effect and short half-life. The advantage of short half-life is you can wean off the propofol very quickly to assess the patient's neurological status if you need to. If patient has raised pressure, medically, sometimes we use mannitol or furosemide or hypertonic saline to drive out the interstitial fluid to reduce the ICP. For fluid management, we want to keep the patient euvolemic with isotonic fluids. The hypertonic saline is used mainly for quick management of severe raised ICP. Steroids, there's no value in giving steroids, and most of centers do not give steroids. The CRASH study in 2006, which is a study that looked at big numbers of patients with head injury and comparing those with who are treated with steroids and those who are not, and they found that there's a significant increase in death in the patient who are treated with steroids, and so steroids are no longer being routinely used. Hyperventilation, so this is more for patient with acute raise in the ICP, and it can effectively lower the ICP. To do with this, we drive the PaCO to less than 35. CSF drainage. Most of patients with severe head injury in the trauma center will insert external ventricular drain. So this is drain that, as discussed before, is inserted into the ventricular space, and that allows both monitoring of the ICP and also allow us to drain the CSF to manage the ICP. Barbiturate coma in patients who have refractory raised intracranial hypertension that we've tried every other methods, then the next option is to give barbiturate, usually pentobarbital, and it also has protective effect for the brain tissue. usually we aim to maintain a burst suppression pattern on the EEG. So this is an example of someone with diffuse axonal injury and from a high-speed accident that's raising the cranial pressure. There's an external ventricular drain inserted, so that hyperdense structure is actually part of the ventricular drain that comes all the way out. That is blood, and that's blood in the ventricles. And the brain overall looks tight. You can see the sulci pattern. The ventricles are very collapsed down. Now, in this patient, because the patient is young and was refractory to all medical treatment, and after consultation, he actually had bifrontal temporal parietal decompressive craniectomy, something like that. Basically, that part of the skull will completely removed to allow for the brain to swell out. Now, is it useful? We used to do a bit more than what we do now because at Alfred, as part of the multi-center studies, we look at patients with diffuse axonal injury, and with a patient that has decompressive craniectomy, it helps to reduce the intracranial pressure, and it reduces the length of stay in the ICU. But we're actually keeping more people alive who has a unfavorable outcome in terms of their neurological status. So once the patient become more stabilized, come out to the ward, and eventually turn out to rehab, there are a few things that sometimes as neurosurgeons or rehab doctors needs to be able to recognize of some of the patients who become plateau in their neurological recovery, or if they have deterioration in their initial neurological recovery. So things to watch out for is things like delayed hemorrhage. This is an example of a patient who was doing well after the initial severe head injury and was transferred from the acute trauma hospital to a rehab center. And a few weeks into the rehab, he had sudden neurological deterioration, and he actually had a traumatic aneurysm, and with hemorrhage from traumatic aneurysm. Now, despite all the optimal medical and surgical treatment, patients still pass away from it. Chronic subdural hemorrhage. This could be related to the sort of a progressive, gradual sipping of the blood into the subdural space, and over time become a chronic subdural hemorrhage, and that can take days and weeks to develop. People who had external ventricular drain inserted before may have a risk of developing infection, so don't forget about infection as part of the cause: ventriculitis, encephalitis, brain abscess, or abscess along the tract of the EVD. Post-traumatic epilepsy, patient who has head injury is at risk of having seizure. With post-traumatic epilepsy, if it's subtle, it might be part of the reason why the patient's neurological status never quite picked up. Post-traumatic hydrocephalus, especially in those groups that has a cranial flap removed, or those with intraventricular hemorrhage, they can develop a condition called communicating hydrocephalus. That's when there's progressive increase in the ventricle size due to the lack of drainage of the CSF, and that can cause deterioration in the initial neurological improvement. And the treatment for that, one is to replace the bone flap, two is to insert a ventricular peritoneal shunt. So this is a shunt that drains the fluids from the brain into the peritoneal cavity. syndrome de Truffaut. So for patients who had decompressive craniectomy, over time as the ICP reduce, the atmospheric pressure can cause pressure effect onto the brain, and it can actually slow down the neurological recovery, or in fact sometimes can cause regression of the neurological recovery. And in that group, the treatment is to put the scalp flap back on and make them as good as new again. That's the end of the talk.
Thank you. We have a few questions from the participants online. So the first one is, post-TBI and initial CT brain is normal. General guideline for consideration of late IC bleed, in what situations this would occur?
The chance that, so if the initial brain CT is normal, it's still, yes. So if the patient is conscious and alert, and the initial CT scan is normal, and so one is, sorry, what's the question again? Can you repeat the last bit of the question again?
Yep, 1 second. So post-TBI and initial CT brain is normal. General guideline for consideration of late IC bleed, in what situations this would occur?
Late guidelines. So you mean the chance of patient developing delayed hemorrhage?
Sorry, she's written again. Cranioplasty, when to use titanium and when autologous?
Okay. So cranioplasty, if the patient's bone flap is preserved, so usually when we do a decompressive craniectomy, if the bone flap is clean, so what we mean by clean is it's not in contact with the environment, so it's not open injury, we tend to keep the bone flap. In Australia, we just basically keep them in the freezer, and we can reuse that bone flap to replace it for cranioplasty. In certain in places that you don't have freezer, you can actually put the bone flap into, suture it into the patient's abdomen. So put it subcutaneously, and you can retrieve it later on for cranioplasty. Now, if the patient's own bone flap is not available, then your option is either to use titanium or acrylic, and you can have it so pre-molded nowadays with a 3D printing. They can actually pre-mold the shape to the patient's scalp.
Thank you. We have another question. What is the recommendation for antiepileptic for TBI patients? When do you treat? How long do you keep patients on antiepileptic? When would you consider ceasing antiepileptic?
Most for patients with TBI, the current recommendation is we use the antiepileptics for the first week. So the first 7 days is mainly for treatment and prevention of the early post-traumatic seizure. So, and whether you extend it beyond the 7 days depends on the underlying injury, the location of the injury, whether the patient has had a seizure, and if you have to extend it beyond 7 days to treat the delayed post-traumatic epilepsy, then that can be at least 6 to 9 months, depends on the type of injury the patient has. For example, if they have a temporal lobe contusion, you probably keep it longer than if they just have an extradural hemorrhage.
We have another question. Any guidelines around commencing BTE prophylaxis?
There's no specific guidelines, there's always a risk of hemorrhage with VTE prophylaxis. Over here at Alfred, we tend to be comfortable about 1 week after the trauma.
And so there's a second part to that question. So recommendations for starting VTE prophylaxis or starting anticoagulation post neurosurgery for ICH.
Usually about 1 week after the surgery, but we also depends on the type of injury, and also depends on the extent of clearance. So for example, if it's an extradural or subdural hemorrhage, most surgeons will be comfortable from 3 days onwards. But if it's intraparenchymal hemorrhage, most people would.
Another person asks, is there any guidelines regarding routine monitoring with CTB post-TBI given risk of post-traumatic aneurysm?
No, there's no specific guidelines for looking for post-traumatic aneurysm. It does happen, but there's no specific guidelines for it.
Thank you. Does anyone in Fairley in Sydney have any questions? I believe that would be no. Someone else has asked, should repeat CTB be performed and when?
For anyone with TBI, would prefer to repeat a scan in 24 hours, and then after that, in the acute setting, it depends on your level of management and what happened with the patient. So if someone just had a acute subdural hemorrhage, but no other injury, and you drain a subdural hematoma, there's no need to keep repeating the scan. Well, I mean, from rehab point of view, if you receive a patient who is from acute trauma center, who has deemed to be stable and come to you for rehab, I would repeat a scan if you find that the patient is not improving in the way that you think it should be improving, or if you think that there's regression in the neurological improvement.
And someone else asks, would you put post-craniotomy patients on anti-epileptic who do not have a seizure?
There's no specific guidelines for that. If it's purely just a craniotomy, I mean, most of us would give them anti-epileptics for 7 days, and then we stop.
Someone also asked, can you tell us a little bit more about post-traumatic aneurysm? Example, epidemiology and risk factors.
It's actually not common. The post-traumatic aneurysm in that patient is mainly because there's some sort of shearing injury involving the anterior cerebral artery. So there has to be a shearing injury to the wall of the vessel. So in that case, it's actually a very uncommon pathology. Now, if it's related to the bony structure, so for example, if you have fracture base of skull or cervical spine fracture that shear the vertebral artery or the internal carotid artery, then there's in that group there's higher risk of post-traumatic aneurysm, and then depends on what type of post-traumatic aneurysm. The treatment is whether you just treat with aspirin or anticoagulation to reduce the thrombosis formation in patients who is shearing cause the injury to the intima and forming an intimal flap, which increase the risk of thrombosis formation, or in whether they need to stand to put in to protect the artery and the flow.
I think this will be our last question for today. What is the role of doing a spinal tap test for patients with communicating hydrocephalus?
That is for the tap test is more if you're unsure whether this is an appearance that you can see in someone who has had cortical atrophy after extensive diffuse axonal injury, or whether this is a true communicating hydrocephalus. So if you are uncertain, then a tap test would be done to see whether it makes any difference once you've drained out 30 to 50 ml of CSF in terms of patient's neurological status, how they walk. Is it very useful? Well, not really. It depends on your degree of suspicion. And sometimes the easier way is just put a shunt in, and then if it's related to hydrocephalus, the patient gets better.
Well, thank you very much, Dr. Patrick Chan. That was a great presentation.
All right, no problem. Thanks, everyone.
Good afternoon. This afternoon I want to talk about some of the medical complications of acquired brain injury, particularly traumatic brain injury, and then look at some long-term outcomes. So I've been a bit selective in terms of some of our current research projects. At Epworth in Melbourne, we've had a long-term follow-up study going for over 30 years now, and this is an indication of where we stood probably 2 years ago. It's probably about 2,500 brain injury patients that have been followed up at least once at either 1, 2, 3, 5, 10, 20 or 30 years post-injury. Most of our patients are funded by a Victorian no-fault insurance scheme called the Transport Accident Commission. Some of our head injuries are work cover. Over half are injured in motor vehicle accidents, 11% in motorcycle accidents, and 18% as pedestrians, 3 as cyclists, and 10 as other causes. Now, in this follow-up study, we invite people to be actually reviewed by a doctor, or there is a telephone interview if they come from regional areas and don't want to come to Melbourne. We give them a questionnaire which we validated some years ago at 1, 2, 3, 5, 10, 20 and 30 years post-injury. And what we basically cover in the questionnaire is neurological problems, medical problems, physical, cognitive, behavioural, and then we look at where they've gone in terms of abilities at activities of daily living, and including things like return to driving and return to work. So if we look at the neurological complaints, and each of these are covered by the various different coloured lines, we can see that fatigue is very common for long periods of time post-injury, and you can think that if it's greater than 5 years, it's probably lifelong. So despite all the physical exercise that we prescribe for them in the first few years after their injury, fatigue is still an overwhelming symptom in 2/3 of our patients. There are 2 things that I want to focus on today in terms of expanding a bit. And one is a seemingly small topic of anosmia post-head injury, and the other is some new papers that have been produced on post-traumatic epilepsy. Just to note here that most of the patients that we see are moderate to severe, and you can see that headaches occur in around 35 to 38% of our patients. So they're not a huge symptom in more severe head injury. We see them much more often in minor traumatic brain injury or concussion. And the same in some ways with dizziness. It's much more prevalent in the more minor head injuries. So one of my PhD students, who is a speech therapist, has just finished a PhD on sense of smell post-traumatic brain injury, and I just wanted in this webinar to share some of her research and some of the new things we've found about this condition. First of all, it's not unreasonable to assume that the olfactory bulb is particularly vulnerable post-TBI due to the mechanics of the injury and what we already know, which is that in traumatic brain injury, the frontal lobe usually gets damaged irrespective of where the skull is struck, and that's really a design problem in some ways. Also, 23% of our patients have facial fractures, and these can damage sinonasal structures and the limbic system, which is central to sense of smell and taste. So olfactory impairment can affect a lot of our patients, yet is not routinely assessed in clinical settings. And this results in some ways in unawareness of the deficit. Now, when Melanie Drummond started this research, a lot of the literature was still quoting 12 to 15% of people post-traumatic brain injury have anosmia. And we now know that these figures grossly underestimate the frequency. If we look at general cranial nerve damage after head injury, and there's been a few papers produced on this, about 9% of individuals have one or more cranial nerve injury post-TBI, and the most common nerves affected are the optic nerve, oculomotor, and the olfactory nerves. And damage to the olfactory nerve is often the primary cause for either partial or complete loss of the sense of smell, otherwise known as anosmia. And we know, well, we have known for some years that the olfactory system regenerates poorly after TBI, and the loss of sense of smell, it has often been quoted, if it goes on for more than 6 months, is likely to be permanent in nature, as there's no real surgical options for treatment. And you can see in some ways why, that the olfactory bulb sends small fibres through the cribriform plate, the sieve-like plate, and often these get sheared off in injury, and it would be very difficult to imagine how they'd grow back through the small holes in the cribriform plate. So the first thing in the study was really to ask people that have had loss of sense of smell, how did it affect you? And we got really 5 groups of answers. Most people talked about personal safety, so they're aware of their inability to detect gas, smoke, or spoiled food. And this can result in some people excessively checking when they're cooking or when they put food in the refrigerator, etc. Now, in Melbourne, one of the things that we really never have to argue with our Transport Accident Commission about is providing smoke detectors for people there where we can show they have anosmia to reduce the personal safety risk if they have gas cooking. The second thing that people talked about was relationships, the familiar smells of loved ones, the reduced intimacy. And this, in some patients, does present significant psychological issues. The third most common answer about how anosmia affected them was in food preparation and the enjoyment of food. They're unable to detect flavour unless excessive. So a lot of people used more spices in their food in order to get some sort of sense of taste, because obviously smell is a big component in what we perceive as taste. And so people with anosmia have reduced sense of taste. And therefore, they restrict engagement in social occasions based around food, going out to dinner with friends. There's no point if you actually can't taste anything. Employment. In a lot of occupations, obviously in people like gas workers and chefs, but in a lot of occupation, sense of smell is either a safety precaution or it does affect your ability to do your job. We had once a chap who was a French polisher, and he opened the factory on a Saturday on his way to the football just to finish a job. And when his friend joined him to drive him to the match, he was unconscious because he hadn't basically opened the ventilation of the factory because it was only a quick job, and he was overcome by the smell of the shellac. Now, he survived it, but it was a safety warning. And then in personal hygiene, and, you know, inability to monitor body odours after exercise, inability to determine whether clothes need washing. And this was a concern of people. So often they washed more often in order that they would not have people telling them that they had body odour. So based on this sort of pilot of what anosmia did, Mel then looked at trying to set up a PhD which had 3 study aims. One was to identify the incidence of olfactory impairment in a consecutive sample of 134 adults post-TBI who were admitted to Epworth Healthcare. The other was to compare the sensitivity of 2 well-used tests. One was called the UPSIT, which is the University of Pennsylvania Smell Identification Test, and the other is the Pocket Smell Test. Both of them are scratch and sniff type tests. And the third aim was to investigate whether age, duration of post-traumatic amnesia, and facial fractures significantly predict the severity of olfactory impairment. Now, for those of you not familiar with the tests, the UPSIT contains 40 odorants with 4 multiple choice options. The olfactory impairment and severity is determined by the number of incorrect responses. For males, it's less than 34 out of 40. For females, less than 35. On the other hand, the pocket smell test, which is very often used and is a cheaper option, contains 3 odorants, also with multiple choice options. 1 error means the potential presence of olfactory impairment. And the smells used are things like peanut butter, mint, and paint thinner. So when we looked at olfactory impairment using the University of Pennsylvania, the much larger test, we found that in our sample, over 2/3, or just on 2/3 rather, of participants demonstrated some olfactory impairment. And when we compared this with the pocket smell test, it was actually 12% more people than the pocket smell test. So the pocket smell test wasn't a particularly useful screening instrument. And of these 66.4% of consecutive patients, 25% had no sense of smell, so complete anosmia. But in addition, of these patients, over half of them were unaware that they had olfactory impairment. So if you simply ask the patient, you're going to miss a lot of people who will not recognise that they've got a problem with sense of smell. Some will mention taste changes, but the majority will be unaware that there's a problem, and therefore that can be a safety issue. So if we predicted olfactory impairment, the patients with olfactory impairment were significantly older than those who are unimpaired and usually had a worse injury as determined by their length of post-traumatic amnesia. The mean UPSIT score did not differ significantly for those with or without facial fractures. So in this study, facial fractures didn't tend to indicate whether someone was likely to suffer anosmia or not. So only age and injury severity significantly predicted UPSIT of performance, but together only explained 10.3% of the total variance. So after getting these results, Mel then followed the patients up at 6 and 12 months to look at recovery and to test this hypothesis that if you didn't recover at 6 months, your sense of smell, you're unlikely to recover. So at 6 months, and we'll just look at the results, we're again looking at this natural progression from baseline. Of the original sample who had olfactory impairment, 89 were reviewed at 6 months. The original sample who had olfactory impairment, 89, 47 participated at 6 months. Their mean age was 43. They had mostly severe traumatic brain injury, and the upsit was the test administered. 68% of these, so 2/3, showed some improvement from baseline, but only 1 in 4 scored within the normal range, and these patients were the ones that had mild olfactory impairment at baseline. So baseline assessment was the only significant predictor of long-term outcome, with age, injury severity and facial fractures being non-significant predictors. If we look at 12 months, 37 out of 76 eligible participants, which again a mean age of 42, were, and with predominantly severe TBI, were tested. 83% of these patients presented with olfactory impairment, with 24 being complete, 24%, again around a quarter, being completely anosmic. 44% did not show any improvement from baseline, and 11% had a more severe level of olfactory impairment. So at 12 months, only 1 in 6 reached any sort of normal limits. And baseline assessment continued to be the only significant predictor of 12 months outcome, again predicting 61% of the variance. So the issue here is that overall, most of the recovery happens in the first 6 months post-injury, that a quarter of patients remain completely anosmic, and that anosmia, although overlooked in acute facilities in many cases, can have significant issues for the patient long term. And our study showing 66% of patients having at least partial anosmia or complete anosmia after TBI, which was much higher than many preceding studies, has now been matched with an American study which shows 72% of their sample had anosmia. As a result of this, in what we'd consider a translation of this research, Epworth has now set up an olfactory impairment clinic, and most of our patients are now tested for olfactory impairment. But as you'd appreciate, it's also something that's very common in Parkinson's disease, etc. May be one of the first signs. So once you set up a clinic, there's a lot of people that use it apart from people with traumatic brain injury. The second medical problem that I wanted to focus on was post-traumatic epilepsy, and patients get confused when they hear that they fitted at the accident site, and so it's worth again defining seizures versus epilepsy. So epileptic seizures are a transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. So as it's often explained, if you fit immediately after a blow to the head, then that's the mechanical distortion of the brain and the reaction to it, rather than it being described as epilepsy. Epilepsy, on the other hand, is enduring predisposition to generate epileptic seizures, and by the neurobiological, cognitive, psychological and social consequences of this condition. In theory, it requires that the individual experience greater than 2 late seizures, seizures after 1 week post-injury, or unprovoked seizures 7 days or greater after the injury. And an unprovoked seizure refers to a seizure that occurs in the absence of another acute brain insult or systemic disorder. Now, whilst this is the definition, it is very unclear still, and even in the literature, which tends to contradict itself, what you do with someone who has late epilepsy, in other words, their first seizure greater than a week post-traumatic brain injury. Do you treat it, or do you say, well, it's not epilepsy until you've had 2, so we won't treat it and wait for the second fit to diagnose post-traumatic epilepsy? And if you read the literature, you'll get different answers in different papers. So let's look at some of the epidemiology, and at the bottom of the slide,
if you read the literature, you'll get different answers in different papers.
If you read the literature, at the bottom I've just put some of the papers, and these ones are all published in the last few years. So just to pick out a few points, post-traumatic epilepsy accounts for 20% of acquired epilepsy in the general population. The likelihood of developing epilepsy is as high as 53% following penetrating brain wounds. So we see those levels in a lot of military series on epilepsy. Head trauma is the cause of epilepsy in 5% of the population overall, and trauma is the cause of epilepsy in 30% of individuals between 15 and 34 years who develop seizures. And 15 to 34 years is the average age of trauma patients in Australia. And we know that the risk of post-traumatic epilepsy increases with the severity of trauma. So for mild head injury, the relative risk is 1.5, moderate 4, and for severe TBI, 29 respectively. So if we look at immediate epilepsy, less than 24 hours post-injury or seizures, the estimated percentage is about 8.9%. Between 24 and 7 days, so early or acute epilepsy, it's again considered transient. Now, in the studies that I'm quoting here, it says not an independent risk factor for late seizures, but in most studies it is considered a risk factor for late seizures. And if you look at greater than 7 days post-injury, the classic late seizure, they're characterised by persistent neurobiologic changes. The risk of post-traumatic epilepsy is highest in the first 2 years and is also associated with a higher risk of mortality than people who don't have late seizures. The paper by Ritter et al. In 2016 looked at 796 patients with moderate to severe TBI, which is a reasonable sample. And he found that there was stronger evidence for a high risk of seizure recurrence subsequent to a first late seizure. So 47% within a month after TBI and 86% totally after 2 years. So he came to the conclusion that a single late post-traumatic seizure, because it often led to other seizures, it would be sufficient for the diagnosis and treatment of post-traumatic epilepsy. So if we look at relative risk factors, and this was a meta-analysis of 111,000 people, the relative risk related to the development of PTA is listed in the table. And you can see the risk factors, early seizures, the risk of post-traumatic epilepsy in patients with early seizures in this study was 5 times greater than those without early seizures. And the risk of post-traumatic epilepsy was sustained for greater than 10 days after a skull fracture. So you can see that if you're male compared to female, you've got a 1.32 relative risk. With prior alcohol use, the risk increases significantly. You have more risk when you're in post-traumatic amnesia than out of it. And in the notes, you can look at the rest of the table. What gives you the rest? Skull fracture, 2.27. And you can see that the ones I've outlined in orange are the ones with the highest relative risk. So I think overall that's really covers most of post-traumatic epilepsy. I'd just like to make the point that the EEG is not a very helpful diagnostic test, and we tend not to do them very often now because they are not predictive of a seizure occurring. And if you're considering stopping anti-epileptic medication after 2 years, again, having an EEG which shows a lot of epileptiform activity may encourage you not to stop the anti-epileptics, but in fact, statistically, it's got no real relevance at all. And stopping them doesn't mean that they'll necessarily have a seizure. So whilst we used to do a number of EEGs in the early days, we've really stopped doing them much now at all. So let's move on to a couple of medical topics relating to patient mobility. And in our follow-up study, we give patients twice daily physio throughout their inpatient stay, and our average length of inpatient is about 32 days. So they get, when they're able, not necessarily in post-traumatic amnesia, but when they come out of post-traumatic amnesia, they get approximately 2 hours of physio a day. So we get fairly good mobility figures, and about 60% of our population eventually get back to what we'd call high mobility, running, jumping, higher level activities, get back to playing sport. And another 30% are able to walk independently, but maybe unable to run or jump. And then we've only got a few percent who have low mobility. Now, we don't have too many studies to compare this with, so it's we can't really make too much of the fact that intensive therapy early tends to help, but that's what we believe. What stops mobility? One of the unique problems relating to traumatic brain injury is the development of heterotopic ossification. And it's one of those conditions that despite all the research that's been done, we're not very much further at being able to stop it than we were when I started looking after people with traumatic brain injury over 30 years ago. You'll see at the bottom of the slide that I'm quoting two papers, Huang et al. In 2017, but also Doug Garland's paper, which was a seminal paper in 1980. Now, in talks, I don't usually quote 1980 papers, but Doug Garland really, over the years, has produced a lot of the literature on HO, even though when you meet him personally, he's got some slightly strange opinions of how to treat it, which we'll go through as I go through. So HO, deposition of new bone around large joints where bone would not normally exist, and we note that the ectopic bone is outside the capsule of the joint. It occurs not only in traumatic brain injury and spinal cord injury, but in stroke, with burns, sometimes with fractures or joint replacement. The prevalence in HO in traumatic brain injury, sometimes referred to as neurogenic HO, still varies in the literature between 11 to 22%. And the mean time from injury to HO development is usually 2 to 3 months. And some reports in the literature would talk about greater than a year post-injury. It is, however, noted that HO rates are particularly high when there's a severe TBI and femoral fractures. In the giving this lecture 10 or 15 years ago, we didn't have too much many ideas as to who was more likely to get HO. And although the etiology is unknown, there are some common risk factors. So associated fractures from trauma tend to add to your list. Prolonged coma and immobility is associated with the development of HO. Systemic infection in the early stage, severe injury, decerebrate posturing, and try not to spell decerebrate that way, severe spasticity. 89% of joints affected by HO are in spastic limbs in traumatic brain injury. The use of mechanical respirators, In severe injury, so you've always got to take into account the extent of neurological damage and again, severe damage as evidenced by a lot of diffuse axonal injuries. And as you probably all know, HO can present as a hot, swollen, tender joint, which progressively loses range of motion despite physical intervention. So patients start to have more trouble walking or sitting if it's in the hip or moving their arms. In our practice, we've found that we've very seldom seen hot, swollen, tender joints, and it's much more common for a physiotherapist to say to us that the patient is losing ground despite my intervention, and the patient will then probably say that they've got some pain in the joint. In 53% of patients, the HO is present in multiple joints, and in 16%, the people that have HO, the joints progress to ankylosis despite any treatment offered. And most commonly affected joints in order of prevalence in TBI are the hip, shoulder, elbow and knee. It's very rare elsewhere. I have seen it in a small group of patients in both the ankle and the knee. Sorry, the ankle and the wrist. The diagnosis and activity levels of HO is best measured by a triple phase bone scan, and the recommendation is to plot the course of HO and the activity that this bone scan should be done at 3 monthly intervals. You can use serum bone alkaline phosphatase, which is elevated in over 50% of HO patients, but it's not diagnostic as elevated serum levels could be due to fractures post-accidents, and in 50% of our brain injury population at Epworth, they have long bone or other fractures. And as you may know, that HO is seen when the bone is mineralised on plain X-ray, which can be some weeks after a triple phase bone scan. So if we diagnose HO by bone scan phase, the first phase is the initial pass through the joint, which is the capillary blush, which indicates greater vascularisation in the area of ectopic bone outside the joint capsule. And the third phase is the incorporation of the radioactive tracer into the bone matrix. We know that if you operate on HO before the bone is cold, in fact, in other words, when it's still very active, that it will come back in abundance. And it's thought this may be due to damage to blood vessels and bleeding around the joint during the operation. Doug Garland, who, as I said, wrote a lot of papers on HO, is an orthopaedic surgeon, and he used to forcefully manipulate joints, which again tore capillaries and things, and would claim that there was no problems with increasing HO, but unfortunately he's the only person in the world that hasn't found a significant problem with forceful manipulation or operation. So we tend not to do it. We don't necessarily wait till the bone scan's cold, but when there's a significant decrease in activity, surgical removal is possible. However, surgical removal has its own problems. In this figure, you can see that neurogenic ossification in the hip in traumatic brain injury, that in the middle B picture, this is severe ankylosis of the joint some 14 months after the initial injury. And when you did an MRI enhanced with contrast, you can see that in many instances the HO has a close relationship between blood vessels in the area, so it can make it extremely difficult to take out and free up the joint. So even when it's cold, it's not necessarily all that easy to get out. So early intervention before activity ceased is advocated to present as much function as possible for TBI patients. To limit HO, we suggest physiotherapy as the mainstay of treatment, and the physiotherapist attempting to maintain the range of movement of a joint without forceful manipulation while the process is active. Other things to use are indomethacin, which gives symptomatic relief but also reduces the amount of mineralisation of the bone. Deep X-ray therapy, it's not often used routinely, but there are still surgeons who use it pre and post surgery in order to try and prevent recurrence of HO. Indomethacin is also used. And the slightly older treatment of bisphosphonates, again, to reduce the mineralisation of the bony matrix. These are expensive and probably no better than indomethacin. The important thing is that once you've got HO, you've got to continue to monitor it, and we have seen some very successful surgical removals, but you've got to make certain that the patients are fit for the operation and that you don't do more damage than you think by trying to take it out. The other thing that I wanted to speak about from a mobility point of view that can certainly impede mobility is spasticity. And, you know, you can have a whole lecture on spasticity alone, so I just want to make a few points. Again, Lance's definition of velocity-dependent increase in the tonic reflexes is a good one in terms of it talks about velocity dependence as part of the upper motor neuron syndrome. It doesn't talk about the local reflex arcs, the disordered sensory motor control. It doesn't talk about the changes in the muscles with spasticity. So a lot of the refined definitions do, and the definition by Pandian in his paper in 2005 is now often used to modify Lance's definition. This is a paper that we published back in 2010 which attempted to show an algorithm for the treatment of spasticity because in those days, as now, botulinum toxin was in vogue, and we just wanted to make the clear point that physical treatment is the main treatment of spasticity and that botulinum toxin is well down the list and is used for predominantly focal spasticity, or that can be used in other conditions. Now, we run a weekly spasticity clinic at Epworth, and we have a database, and whilst I'm not going to go through all of the data that we collect, I just want to make some points of why it's useful to have a database when you're treating to know what's successful and what isn't. So I've pulled some figures out as a matter of illustration. Some of them aren't statistically valid in terms of not a large enough sample size. So we established the clinic in 2009. We've now, when we first took this data out a couple of years ago, we'd treated about 128 patients in over 282 clinics. We found that the majority of our injections in over 50% of patients were in TBI, and then 50% in other neurological conditions, MS and stroke. The majority of injections we were doing were in the lower limb, 58%, upper limb 36%, and both limbs 5%. The gender difference in our clinic wasn't vast. We tended to inject younger people, average age 4.8. But as a point of illustration, the time since injury when we started this clinic was 8.7 years. Now, the issue with this is that we are now treating people as early as possible, and by that I mean as soon as we start to lose ground in terms of not being able to put a joint through its full range of movement, or losing ability either with upper limb or lower limb, where the physio or occupational therapy is losing ground, then we will inject. Now, sometimes they lose ground from week 1, post-traumatic brain injury, therefore we will inject them at week 1. We were interested to find what muscles we injected in the clinic. In our clinic, we have 2 doctors, a physio and an occupational therapist, all in the room together when we assess and treat patients. And these graphs really show that the muscles that we inject and the frequency of injection. And I think when we're teaching registrars in our clinic, they've got to become experts at the most common muscle rather than the smaller sort of esoteric muscles that you can inject that are maybe a bit more difficult. So you can see that biceps, flexor digitorum superficialis, the elbow flexors are probably the most common in the upper limb. Gastroc and soleus and rectus femoris, tib post are the most common muscles in the lower limb. Before we had the database, we really had no idea. We had an opinion on what we injected, but this gives us accurate data. Now, we measure the tone by using the modified Ashworth scale. Note that I said measures tone because it doesn't measure spasticity, and this is the modified Ashworth scale. So it's pretty gross. Why do we use it? Well, because when you get toxin on the PBS for upper limb spasticity after stroke, then one of the things that you've got to write in order to get the free toxin, or you did have to, was their score on the modified Ashworth scale. So we had to collect it. The other reason we collected is that most of the literature and research on traumatic brain injury, whether it's justified or not, uses the modified Ashworth scale. And so we looked at our modified Ashworth change in some of the most common muscles we injected in the first sort of 93 clinics. So again, I'm not showing these for statistical reasons. It's really just to show that you do have to monitor what you're doing and query if you're not getting a particularly good result. These again, a series of upper limb muscles and what change we were seeing. And sometimes, and this is the nonsense in some ways of the modified Ashworth scale, we were getting significant functional change on goal attainment scoring without a huge amount of change in terms of the actual single muscles we were injecting as measured by the modified Ashworth. So in our clinic, we're all about function, and for walking, we use the 6-minute walk test and the 10-metre walk test to measure speed, and we do the 10-metre at a self-selected speed and then as fast as possible. And we record whether they've got shoes and socks on, whether they need gait aids, etc. Now, again, this is only 13 patients and just for illustration, but we just wanted to see what was happening with the first injection in things like gastroc and soleus in terms of their 6-minute walk test. And we were overall in that those patients getting a difference of about 20 metres in about 300. Now, you can do the stats on this and look at a p-value of 0.03, but it's actually meaningless because what you're really wanting to measure is what that extra walking distance did for the patient. If it did nothing, then it's not particularly useful. If it allowed them to walk to the toilet, for example, from their lounge room, whereas they couldn't before, then that might be extremely useful. So it's all about functional change, not about reduction of spasticity in muscle, or things like, you know, we've got a statistically significant increase in walking speed, which also doesn't mean anything unless it means something, like I can now get across a traffic light when I'm walking in the community without it turning red. That sort of change is meaningful. So we tried to look at that by using a modified version of Jacqueline Perry's functional walking categories, which she published in 1995. And she described a gait speed of less than 0.1 metres a second as a fully housebound physiological walker. And she went to a speed of fully independent community walker at greater than 0.8 metres per second. And she had a number of different grades in between that. Incidentally, 0.8 metres a second is the minimum average speed required to cross intersections in Australian cities. It's actually a different speed needed in America, just for interest. If we look at the 10-metre walk test and the average self-selected speed in 18 patients, between injections, so pre-injection, the green, post-injection, the review, and obviously we've got data on what we injected, the graph shows that the average speed of patients on the 10-metre walk test did improve. It didn't reach statistical significance, but you can see that the 0.8, which separates community walkers from non-community walkers, was met by patients, and therefore in those patients it was a significant result. So that's why I want to emphasise that any treatment of spasticity should be all about goal setting, and that the goals have to be particularly, well, not only specific, but definitely measurable, attainable in the time that you nominate, relevant to the patient, and they've got to be attainable, not just on the never. So I just want to show you one slide of how you turn patient goals that are generally pretty broad into SMART goals. So one of our patients wanted to be able to put the left hand on the handlebars of his bike. And so in order to make this a SMART goal, we tightened the time. And so we made that to be able to hold a handlebar with the left hand for a period of 10 minutes, 8 weeks after our injection. And in our clinic, 8 weeks is the usual time we review patients. That is while the toxin's still active and probably at its maximal effect, but sometimes too early for a lot of functional change. So we could easily see them also at 12 weeks or beyond. Mobility, most patients say, I just want to be able to walk further. Well, that's relatively meaningless. So you've got to have a distance and a time. We could have said that the patient needs to walk 500 metres, but that wouldn't be realistic or attainable. It would have been better if we said the patient needs to walk 420 metres, because in doing that they could reach the corner store, whereas 400 metres wasn't good enough, and that would be a smarter goal. So I'm just trying to give you some idea of the fact that the goals do have to be SMART, and it's not just a term in order to measure them. And then in order to measure your ability to help the patient goal set, and it's a collaborative thing, you've got to look at the goal achievement. So these are 363 goals. If it was the same as baseline, we said they weren't achieved, and we didn't count partially achieved. So it had to be fully achieved or nothing. As you know, you get 0 if you achieve your goal. And currently, the last time we looked at our database, we were achieving, or patients were achieving, just over 70% of goals, which was an improvement from baseline, but it still leaves a lot of room for improvement. All right, just on another topic at the other end of head injury, where it's not moderate to severe, is concussion. And in the last 2 years, we've set up a concussion clinic, which is being very well attended at this stage. It's a big deal in the community, highlighted by sport, and particularly in our brand of football in the AFL. There's been a lot of work on concussion and what it means. So the definition, and there's a lot of definition, but this is one by the American Association of Neurological Surgeons, a clinical syndrome characterised by immediate and transient alteration in brain function resulting from mechanical force or trauma. You will note the term transient alteration in brain function. So we are expecting it to get better. It's a mild injury to the brain from a direct or indirect force to the head, causing, again, temporary disruption of normal brain function. And in 10 to 20% of cases, it involves loss of consciousness. So the difference between that and mild traumatic brain injury is the temporary nature of it, and there's often a dividing line which is not always clear as to what's concussion and what might be a more permanent set of symptoms from mild traumatic brain injury. 24 hours PTA and things are often quoted, or there's a whole lot of definitions of mild traumatic brain injury, but sometimes it's difficult to quantify whether it's concussion or a mild injury. Now, it's important to recognise that 80 to 90% of concussions, the symptoms will resolve within 7 to 10 days. And they're not the patients that we often see. We see the patients whose symptoms persist longer than this, and the whole point of our clinic in rehabilitation is to use the expertise of our staff, medical and our therapy staff, to try and turn off these persisting symptoms before there's a lot of other problems. And the other thing to note is that many of the symptoms of concussion evolve and might be delayed for several hours or even a day after the actual trauma. So there's symptoms like headaches, nausea, fatigue, dizziness, concentration difficulties, confusion, or the emotional domains, irritability, depression or anxiety. Now, there's a lot of post-concussion symptom checklists. We're at the moment using this one, which was developed in the States, and each patient that comes into the emergency department at Epworth and everyone that's referred to our clinic, we use this symptom checklist. It is said that 4 symptoms on this list being positive, the diagnosis could be made of a post-concussive symptom. Physical symptoms are the most common, but cognitive emotional symptoms are the ones that are likely to persist longer than 3 months. And in one study published a long while ago now, the best predictors of symptom persistence were noise sensitivity and anxiety. So we also use these to look at the effectiveness of our treatment. Because the physio uses the breast and other balance tests, I tend to use the Sharp and Romberg test. And the reason that I use it is that a lot of our younger patients, particularly our schoolboy footballers, are dragged in by their mothers and basically don't believe there's anything wrong with them because, they're not either telling you their symptoms, they want to go back to playing sport the next week. And very often when you do a Sharp and Romberg, and particularly when they get to single leg stance, eyes closed, they can't do it. And they realise then that maybe they have got symptoms that are a little worse than they thought. So it's a way of sometimes demonstrating to people that, that the symptoms may be significant and they should listen to what we say. So our clinic is multidisciplinary screening assessment, and we try to manage the post-concussive symptoms, and we haven't seen the same patient twice, so everyone has a unique combination. The particular therapists that are used are a vestibular physio. We've got a physio that specialises in neck problems, and we've got an exercise physiologist. So we find that the 2 most worrying symptoms for the patient are probably headache, and it's probably a combination of the physio and the doctor that looks after that, and vestibular symptoms. And then later on, we also have a neuropsychologist, and for the emotional symptoms, a clinical psychologist, and then later on the vocational occupational therapist to get them back to work. So we find in our clinic that almost 2/3 of our patients are referred from general practitioners, our male to female ratio is pretty similar at the time. The patients have a slightly higher rate of anxiety and depression than in the normal community. The interesting thing is that the patients generally, it's not their first concussion. So about half of our patients that we see have had previous concussion, and in our study, almost half suffered loss of consciousness. Most commonly, we're seeing sporting injuries, but they're falling off bikes and just falls or other sorts of things and assaults. So this is the sort of way you can use a post-concussion symptom checklist. And in this case, we've got 32 patients and over a time in the clinic ranging from 9 days to 1.5 years, you can see that in the collective group of patients, there's been significant reduction in symptoms with both time and active treatment. All symptom categories significantly decreased. We also asked them about what they feel their activity level is. And the average on admission is, well, my activity level is about 33% normal, to discharge probably about 80% normal. Also, we use depression and anxiety scales, and you can see that so far in the early days of the clinic, with clinical psychological counselling, we are able to reduce their depression, anxiety and stress. Now, I remind you again that in concussion, most of these symptoms resolve normally within 2 weeks. So if you get symptoms going for weeks and months, there can often be further psychological overlay, particularly depression and anxiety, and these have to be actively treated, otherwise they tend to persist. So our clinic is trying to treat aggressively symptoms in the first few weeks to try and turn them off before these people have more chronic problems. And there's a lot of work now being done on concussion. There's biomarkers that are looking valuable for looking at outcome, vestibular evoked responses. Some people are claiming that they are finding lesions on functional magnetic resonance imaging, whereas most of the standard imaging that's done is normal. And like everything else, repetitive transcranial magnetic stimulation is being trialled in this group of people as well. So it's an emerging field where we still don't know a lot of the answers. I want to finish the talk by looking at our long-term follow-up study again, and looking at a group of patients where we've asked them about personal, domestic and community activities of daily living. And you'll see by the graph, and that we've got a control group in this case, but you can see by the graph that as the activity gets more difficult, less patients become independent. So we get about 2/3 of our patients back to driving, for example, whereas almost 100% of them are independent in personal activities of daily living. And I think in a talk like this, or any talk on brain injury, it's worth reminding that the main rehabilitation thrust in brain injury is helping people understand the role of the frontal lobe. And this, which I've included in your notes, is a simple graph breaking the frontal lobe into geographical regions, but listing the sort of problems that you have. And in most patients, it's not the physical recovery that's the problem, it's the persistence of these problems and their impact on family, work and any sort of community life. If we look at behavioural changes, we know that things like irritability, despite all the treatment, and this is patient self-report. So at 10 years post-injury, 60% of our patients are still reporting greater irritability. 30% are recognising that they're more self-centred, etc. And emotionally, our patients have double the community controls of anxiety and depression, and this persists These are the results from both the 5 and 10-year survey, which shows the need for follow-up and active intervention. And again, despite treatment, a whole persisting range of cognitive problems. Our patients are more socially isolated, so these are part of the statistics that in the normal population, 34% of young males would have never married by 30 to 34, whereas in our population it's 49%, so they're not able to form relationships. And the final statistic is the social isolation, despite better community support, that 60% of our patients report social isolation at 10 years compared to 18% in the control group. So thank you, and happy to answer any questions in the last few minutes.
Thank you, John. We have a few questions we'll get through quickly. So one person has asked, post-TBI, are the upsit and PST used as a standard?
Sorry, I missed that question. I'm having trouble with my mic. Yeah, could you repeat that?
Post-TBI, are the upsit and PST used as a standard?
Up to date, there's been no standard. We are strongly suggesting that the upsit's used because the small pocket smell test is not very accurate. There is another test of 12 smells that the neurologist used, but we haven't evaluated that yet. So I'd suggest the upsit should be the gold standard.
Thank you. Another person has asked, are there any restorative rehab strategies for anosmia, or is management purely compensatory?
Well, I think we have to say now that it's compensatory. We don't have a treatment for anosmia. There's been a lot tried. There's been a lot of psychological interventions tried, but no, treatment is not something that we're able to do. So a lot of our counselling is really reflecting on those 5 issues that I outlined, or that Mel outlined in her study early, that affect patients, and we sort of talk to them about how to avoid problems associated with anosmia, with their anosmia, rather than being able to treat it.
Someone has also asked, what percentage figure do you quote to patients when discussing their lifetime risk of post-traumatic seizures?
Well, look, a lot of our patients, if you've got a moderate head injury, nothing much to see on your CT scan, then your risk of post-traumatic epilepsy might be 1 or 2%. If it's at 2%, it's still probably almost 4 times normal, but you don't make a big deal of it. So in family meetings, we certainly emphasise it where people might have a 10 to 30% risk, and just sort of mention it casually in passing, but tell them if they've got a 1 to 2% risk that it's highly unlikely and that we're just mentioning it for completeness. Again, we don't do anything routinely. You try and tell patients what's relevant to their particular situation.
Is NSAIDs useful for prevention or for treatment? Which treatment is most common, NSAIDs or bisphosphonates?
When I started, it was bisphosphonates. Now, the only non-steroidal anti-inflammatory drug that has been proven is indomethacin. So whilst there's a lot of other NSAIDs used, indomethacin's the only one that they've got evidence for, and most people use indomethacin because A, it seems to work on the demineralization. It also gives symptomatic relief, and it seems to be just as effective as the much more expensive drug of the bisphosphonates. So indomethacin is by far the most commonly used drug if you're going to use a drug at the moment.
For symptomatic reliefs from HO, does all different types of NSAID is as effective or only indomethacin?
I believe that others are effective, but if you're looking at evidence-based medicine, the only one that's got the evidence, and this was in a British orthopaedic journal, was indomethacin. But we believe that certainly the others give symptomatic relief, but how good they are at preventing or reducing mineralisation, we don't know. We don't even know how the anti-inflammatories work, whether it's through some action on prostaglandins or not. It's just not very clear. So in all, this modern science, our treatment and understanding of HO is still pretty rudimentary.
And our last question is management of headaches post-TBI, concussion, anything special?
Yes, look, the management of headaches post-TBI, in my opinion, is the same as the management of headaches without having had a TBI. In our post-concussion patients, the thing I should have said is that our main emphasis in post-concussion is to get people active quickly. We don't certainly have them lying around in bed at all if we can help it. But with headaches, we tend to use a combination of anti-inflammatory, something like Nurofen, and Panadol, paracetamol, because that combination tends to treat the most common causes, which are neck-related and tension. And so that's what we use to start with, and that often helps people. Then we have to go on to other more powerful medications if they don't respond. I use a fair bit of NDEP, for example, in headaches, but most patients respond to probably some manipulative therapy on the neck, plus an anti-inflammatory, plus a simple analgesia, plus psychological counselling.
Well, that's all the questions, and I believe that concludes today's presentation. Thank you so much, Dr. Olver, for your time and your wonderful presentation.
Thank you very much. Pleasure.